Thank you very much. I don't have any conflicts of interest. I think everyone here is well aware of the risk factors that might be considered chronic: hypertension, dyslipidemia, diabetes, smoking, etc. But there's been a lot less known about the concept of triggers and acute risk factors. So what is a trigger? It's an activity that produces short-term physiologic changes that may lead directly to onset of acute cardiovascular disease. And acute risk factors is defined by Toffler: short-term physiologic change, such as a surge in arterial pressure or heart rate, an increase in coagulability or vasoconstriction that follows a trigger and may result in disease onset. Now, there are a number of triggers that have been described associated with cardiovascular events, and most of these have to do with either emotional or physical stress. These include things such as the wake-up time in the morning. We know that there's circadian rhythms and that there's an increase in MIs between around 6 a.m. and noon, and this is also true of strokes. The day of the week, Monday, today is Monday. Seasonal variation, winter, cold, blizzards, and you might think that we escaped that here in lovely Southern California, but we do not, as I'll show you. The winter holiday season coming up, heat waves, infection, influenza, some fine work by Mort actually on influenza and the importance of vaccinations. Physical activity, heavy, moderate exertion, sexual activity, psychosocial, emotional upset, anger, anxiety, bereavement, work-related stress, high-pressure work deadlines, which I'm sure we all deal with, sporting events, which I'll say a little bit about, lack of sleep, overeating. I always say it's a good thing we do our internships when we're young and not old. And then there's certain population stressors. This can include things such as earthquakes, blizzards, wartime missile attacks, sporting events, maybe terrorist attacks, high air pollution days, again, respiratory infection, flu season, certain drugs, cocaine, marijuana. So this is work by Toffler and Muller and others who really looked at and interviewed patients who had acute MIs and looked at what they were doing shortly before the MI and compared that to control times. And they found that about 18% of patients who had acute ST segment elevation MIs had emotional upset prior to the MI, moderate physical activity, heavy physical activity, lack of sleep, overeating, and there were some others. And a good example of this was this paper by Middleman, who looked at episodes of anger as a potential trigger of myocardial infarction and found that if you had an episode of anger, you had an increased relative risk of having an MI at 2.5 in the first hour of the episode of anger, and then it was still elevated at 2 hours, but if you cooled off by about 3 hours, you were less likely to have an MI. And I always tell myself that when I'm driving on the 101 freeway or the 5 freeway to get down here to Anaheim this morning. Road rage is one of the triggers. So why is this? Why is stress a potential cause related to these triggers? So we know that with stress, either physical or emotional, there is an increase in catecholamines, there's an increase in stimulation of the sympathetic nervous system. And this can have several adverse events. One is it can increase blood pressure, it can increase DPDT or contractility of the ventricle, this can increase oxygen demand, but it also may contribute to things such as atherosclerotic plaque fracture of the vulnerable plaque. You can also see increases in coronary tone and vasospasm with stress, which will decrease flow. With an increase in catecholamines and sympathetic nervous stimulation, there can be an increase in platelet aggregability, a decrease in fibrinolytic activity leading to a relative hypercoagulable state. All of these can lead to arterial thrombosis, acute MI, and sudden death, again suggested by Toffler, Muller, and others. Well, here in California, and for those of you out of state, welcome to California, we sometimes have a state of shock, and everyone who lives in Southern California is living on or near an earthquake fault line, and this is the famous San Andreas fault. We're somewhere down here. But this is the Northridge earthquake that occurred January 17th, 1994 at 4:30 a.m. I lived about 10 miles from the epicenter of that. And so at 4:30 in the morning, it sounded like a train went through our living room. Just about everything made out of glass broke. Our chimney fell over. The refrigerator ripped out of the walls. We had cracks in the walls, and it was probably one of the few times I thought I might die. I didn't die, but I can tell you that my heart rate was racing. And I'm sure that my blood pressure was elevated if I had been able to take it at that time. So with Jonathan Lior was the fellow in our lab at the time, we looked at a number of different aspects of the effect of the Northridge earthquake on coronary events. One was we canvassed 72 coronary care units in LA County, and we looked at the number of CCU admissions for MI the week before, and then the week after the earthquake, starting on the day of the earthquake. And there was an increase in CCU admissions associated with this earthquake, an increase of about 35%. And if your hospital happened to be within a 15-mile radius of the epicenter of the earthquake, you were much more likely to see increases in CCU admissions for MIs than if your hospital was beyond a 15-mile radius. This was one of the freeways, which luckily I did not drive on my way to work. Unfortunately, there was a police officer who was driving over this stretch of the freeway when it collapsed, and sadly he was in this body bag. We did another study with the LA Coroner's Office looking at the total death and different kinds of death. If you look at January in the control years, 91, 92, 93, the number of deaths per day was pretty flat. But you can see that on January 17th, there was a big increase. Some of these were due to trauma. Unfortunately, that police officer who was in the body bag is part of this bar. But you can see things were pretty flat during the control years. But actually, there was a larger number of deaths related to atherosclerotic heart disease, as shown here. And again, the control years, it was all very flat. And if you went through these medical histories, most of these cases gave histories that were something like this. Earth started to shake, person clutched chest, fell over dead. It was very common. In fact, there was a significant increase in sudden cardiac death on the January 17th, 1994. We did a third study looking at all death certificate data in LA County. And you can see the control years here, 92, 93 are pretty flat, but 94 on January 17th, there was a significant spike in all deaths, deaths from heart disease, deaths from ischemic heart disease and atherosclerotic heart disease. And it's interesting that you see this spike, but then in the following couple weeks, there's actually a trend downwards. And so what does that mean? Well, one interpretation might be that you have patients who are at risk of dying, and you hasten the death by maybe rupturing that vulnerable atherosclerotic plaque earlier than it otherwise might have ruptured. Another concept is that there might have been a preconditioning or a conditioning phenomena that occurred. If you look spatially, you also saw differences in deaths. This is the average number of daily deaths due to ischemic and atherosclerotic heart disease in the days before the earthquake, January 1 through 16, 1994. And the highest number here is about 1.15 in the dark. And you can see here's the epicenter. So this is the control. This is the day of the earthquake. And you can see now the dark area here is, is 4 to 5. And the deaths sort of cluster around the epicenter spatially. We didn't see increases in other kinds of cardiac deaths, such as hypertensive heart disease, cardiomyopathy, death from valvular heart diseases, cerebrovascular disease. I'll just mention there have been now about a half a dozen of these earthquake papers in the literature also confirming these findings. This was a building that was not too far from where I lived. I also happened to be living in Boston from 1974 to 1978 and got to experience some very lovely blizzards there. This was a paper by Glass looking at increase in deaths from ischemic heart disease after blizzards. Death certificates in eastern Massachusetts were examined after 6 blizzards, 1974 to 1978. They were examined to identify effects of mortality from these storms. The total number of deaths was 8% higher in a blizzard week than in preceding and subsequent control weeks, 114 versus 105 deaths per day. Deaths from ischemic heart disease rose by 22% in a blizzard week from 37 to 45. The increase was greater in men than women, and since the increase in ischemic heart disease deaths continued for about 8 days after a snowstorm, was felt that the effect was likely related to activities which might include things like shoveling snow, which you know can markedly increase oxygen demand. We became very interested in seasonal variation, the concept of seasonal variation of cardiovascular death. There had been some reports that deaths were more common in the winter due to ischemic heart disease, but most of these studies have been done in cold climates. We said, well, okay, what about Southern California, where it's usually a pretty modest winter. We don't get the snow and the very, very cold weather. So we looked at mean coronary deaths. This was from death certificate data that was averaged over 12 years, looking by month. And what we saw was a U-shaped curve here with the highest incidence of deaths from coronary disease in January and December, and then the lowest rates in the summer and early fall. Recently, Brian Schwartz, in collaboration with others and folks from Research Triangle Institute, collaborated with us to look at these same issues in a number of different states and a number of different cities across the United States: Pennsylvania, Massachusetts, Washington, LA, Georgia, Texas, Philadelphia. And no matter where we looked at it, we saw the same U-shaped pattern, which is seen here. So average monthly all-cause death rate and cardiac death rates seem to follow this U-shaped curve, where again, January and December seem to be the worst. This looks at, again, all-cause death rate, and we also find that this correlates with influenza. So as influenza goes up, so there's all-cause and cardiac death. It inversely correlates with temperature. So the cooler the temperature, the more likely cardiovascular events occur. And one of the theories, there's several theories. One is that increased vascular resistance, more likely to have a thrombosis during the cold, increased oxygen demand as you're shoveling snow or going out in the cold. And then there were some other correlations here as well with dew point temperature, not quite as much with barometric pressure. Well, the holidays are coming up, and one of the studies that we did was to look at the total number of coronary deaths by day in LA County. And I can tell you that the temperatures, especially in December and January, tend to be pretty flat here in Southern California. But if you look at this data, you kind of go along here in November, here's Thanksgiving, and then this curve starts going up. There's a peak around Christmas and a second peak around New Year's, and then it falls. And our group and Philip's group in San Diego have looked at this, and there actually is a significant increase on Christmas Day as well as on New Year's Day. And there's a lot of speculation about why that is: stress of the holidays, increased intake of fatty foods perhaps, maybe excess alcohol intake, dealing with obnoxious relatives during the holidays. All that stuff can cause stress, so there could be both emotional and some degree of physical stress. Now, I want to say a little bit about sports. This is data from a paper that was published in the New England Journal of Medicine in 2008, and it looks at daily cardiovascular events in a study population in Germany during control periods, which are shown down here. And these red spikes are gains when Germany was in the World Cup. And so there were these increases in cardiovascular events associated, especially with very intense games. Well, all right, so Game 7 I guess wasn't that bad. Yeah. So we got interested in this concept related to the other kind of football, that is Super Bowl football. Again, intense European soccer was associated with an increase in cardiac events, less information about high-profile sporting events in the U.S. The purpose of our study was to determine whether there were changes in local death rates when a football team representing a local population, LA, participated in the Super Bowl. We analyzed death rates from LA County for the day of and 2 weeks after a losing 1980 and winning 1984 Super Bowl and compared them with deaths for all other days from January 15th to the end of February for 1980 to 1983, and then for 1984 to 1988 control days. We also looked at other controls, including the same days of the Super Bowl and non-Super Bowl years. Now, the first thing we looked at was the Super Bowl, and LA has only been in 2 Super Bowls. One was 1980, and that was the Los Angeles Rams, and they lost horribly to the Pittsburgh Steelers. The Rams had been in LA for many years. They were a much-loved team. This was a very intense game. There were 7 lead changes. The Rams were underdogs. The Rams went into the 4th quarter with a lead, but then went on to lose, and the game was played locally in the Rose Bowl. In contrast, in 1980, the LA Redskins beat the LA Raiders, beat the Washington Redskins. The Raiders had been in LA for only a few years, and the Raiders had a victory from the beginning. They won by a large margin. The game was played out of state. It was a pretty boring game. So when we looked at mortality rates, all deaths during the control times versus the 2 weeks associated with the Super Bowl, there was actually an increase with this 1980 loss. There was an increase in circulatory death and ischemic heart disease death. When we looked at data from 1984, and the Super Bowl was played almost, just the same date, almost in January, but this Super Bowl was won, and it was a very boring game. There was actually a slight decrease in mortality rates, a slight decrease, although not statistically significant, in circulatory death, and no difference in ischemic heart disease deaths. Well, this was back in 1980, and the question is, would the same thing apply if we were looking at more recent Super Bowls? And actually, Brian Schwartz in our group recently published a paper where he looked at a number of other Super Bowls, some on the East Coast, some in the Midwest, and found very similar results from Super Bowls that had been played in the 2000s. Now, interestingly, there was a study that looked at fat intake after losing a football game. On Mondays following a Sunday NFL game, these investigators found that saturated fat increased 16% and food calorie intake increased 10% in cities with losing teams and decreased in cities with winning teams, and is unchanged in cities without NFL teams or in cities with NFL teams that did not play that day. Could that have played some role? I don't know, maybe. So our first Super Bowl studies were done in the 1980s, and again, we looked at more recent Super Bowls where, statins and antiplatelet therapies and drug-eluting stents are available, but pretty much saw the same findings. Okay. So I'm going to just actually skip to this part because I want to say a little bit about, is there something we ought to do about this? Well, there's no control randomized studies on this issue. I think that it would be good if there were, but just common sense suggests that we want to control all long-term risk factors for cardiovascular disease. We want our patients, of course, to be on statins for dyslipidemia and antihypertensive drugs, stop smoking, control diabetes and weight loss. Stress reduction, anger management, behavioral modification have been shown to work in some studies. Exercise programs to condition the heart, avoiding certain forms of heavy exercise such as snow shoveling, especially if one is deconditioned. Avoid overeating. Maybe slow, gradual awakening and gradual change in posture should be considered. And limiting time outdoors during high air pollution days. And of course, medicines, perhaps aspirin, beta blockers, calcium blockers, statins, or in some situations, prophylactic nitroglycerin. As more has studied and shown, flu shots work and will decrease the risk of cardiovascular events. And of course, devices, ICDs, public access defibrillators. And this was a study that was published by Blumenthal in 1997, looking at cumulative probability or proportion of event-free situations. Stress management was very effective in decreasing cardiovascular events. And then exercise was not quite as good as compared to usual care. And here stress management included exercise, meditation, massage, counseling, and this sort of thing. So in summary, stress, physical or emotional, can adversely affect the heart by sympathetic and catecholamine-mediated mechanisms. Wake-up time, physical exertion, emotional stress, overeating, lack of sleep may trigger cardiac events. Emotional and physical stress associated with natural disasters such as earthquakes, blizzards, the holiday season, and intense sporting events can contribute. And recognizing the triggers, modulating stress, and treating with some pharmacologic therapies may reduce the effects of these triggers. Thank you very much. I'd like to acknowledge Drs. Lior, Schwartz, Research Triangle Institute, who handled all the statistics for these studies, the County of LA, and LA County Coroner's Office.